Hello, everyone, and welcome to AFTD's Educational Webinar Series. Today's webinar is What You Should Know About Behavioral Variant FTD. Our presenter is Nupur Ghoshal, neurologist at Washington University in St. Louis. I'm Sharon Denny, Program Director at AFTD, and on behalf of all of us here and Dr. Ghoshal, I'd like to thank you for joining us today. Before we get started, I want to go over a few items to help you participate in today's event. Dr. Ghoshal will present our information in several parts, and following each part of the presentation, there'll be an opportunity for some questions. We ask that you submit your questions by typing them into the questions section, which is located towards the bottom of your control panel. Please send your questions as you think of them. There's a lot of interest in today's talk, and I imagine we'll have many questions. We will ask as many as possible in the time available, and so we're going to try to screen them as we go, and we have help with the staff to do that. Your microphones will be muted for the duration of the presentation. This will allow everyone to hear the presenter clearly. If you have any technical issues, please write a message in the questions box, and AFTD's Lauren Gaudier will help you to troubleshoot. Today's webinar is scheduled for 90 minutes. We are recording the presentation, and we'll post it on AFTD's website and YouTube channel. If you find it informative, we would love for you to share it with others who might be interested. For those of you who are meeting us for the first time, AFTD is a national nonprofit organization whose entire focus is on frontotemporal degeneration. AFTD works to bring help for those affected today and to bring hope for a future without this disease. We do this every day through advancing support, education, research, advocacy, and awareness. AFTD provides resources and support services for people living with FTD, their families and friends, and the professionals who serve them. These include current accurate information on our website, as well as a companion site for children and teens. We have the only helpline in the country that's devoted to FTD. Each call and email we receive is answered by a specially trained staff member. We have a national network of support groups with over 80 affiliated FTD support group leaders as part of it. AFTD provides continuing education and networking opportunities to help the facilitators meet the needs of families in their community. New groups are needed, and new facilitators are always welcome. The Comstock Grant Program provides direct assistance for respite travel and travel to an FTD conference, and innovative grants for persons living with FTD so that they can purchase goods or services that will make their lives a little easier. And Partners in FTD Care, which is a quarterly publication for health professionals and family caregivers alike. Each topic is developed by a multidisciplinary committee of professionals and lay experts. The topics are explored in depth with case examples and practical strategies for managing care. And finally, a few quick reminders that you might want to jot down and keep in mind. AFTD's 6th Food for Thought campaign is coming up soon. It's September 23rd through October 8th. Sign up to host an event and join the fun. Serve some food, share your story, and spread awareness of FTD. And you can help make this the year that there's an event in every state at the same time. Join the FTD Disorders Registry. This secure electronic database collects information from people with any of the FTD disorders and from their care partners and family members. Your participation will increase the understanding of the disease and will fuel future research. And mark your calendars. AFTD's 2019 Education Conference will be Friday, May 3rd in Los Angeles. You won't want to miss it. And of course, the best way to stay current with all the news and upcoming events is by signing up for our newsletters. You'll find all this and more on our website at www.theaftd.org. And now it's my pleasure to introduce our guest, Dr. Nupur Ghoshal. Dr. Ghoshal is a neurologist who provides care and support to her patients with the Washington University Physicians in St. Louis, Missouri. With over a decade of experience in her field, Dr. Ghoshal serves as an associate professor of neurology and psychiatry at the Washington University School of Medicine. Dr. Ghoshal graduated from Northwestern University's Feinberg School of Medicine in Chicago. She completed her internship and residency at Barnes Jewish Hospital and a fellowship at Washington University. She holds a PhD in cell and molecular biology from Northwestern University as well. Her research is focused on the mechanisms underlying neurodegenerative disorders, including the tau protein in Alzheimer's disease and the progranulin protein in frontotemporal dementia. She's dedicated to delivering high quality and compassionate care to her patients and remains a distinguished member of the American Medical Association and the American Academy of Neurology. In her free time, Dr. Ghoshal enjoys the fine arts, theater, attending museums, and the ballet. Welcome, Dr. Ghoshal.
Thank you. Thank you for having me and having this opportunity to speak to such a group interested in a topic that's near and dear to me. Let's get through some of the technical aspects here. Looking good on your end? Okay.
Yes, it is. We're good.
Okay, good. So again, thanks for the opportunity to speak to you all about the bvFTD. Just a few items to clarify right off the bat. Sharon did a very nice job of introducing kind of my background. A few other hats that I wear in terms of research that I do and clinical trials that I conduct are on this disclosure slide. You'll see that I'm funded by the AFTD as well. And that provides a certain perspective when I give these talks in terms of the bench side and the bedside as well. Let's make sure that we have some of our terminology together and that we're on the same page in terms of moving forward here. So what is dementia? We talk about that when folks, patients come to us who are having cognitive and behavioral symptoms. We'll be focusing obviously more so on the behavioral symptoms component today, but this is at a point when it's interfering with their work or their usual social activities. And more importantly, it represents a decline from their prior higher levels of functioning. So it's all about each person and their own trajectory. It's not an across-the-board type of thing. The way we do these assessments, and I'll do a deeper dive in several more slides, is most things in neurology are all about the history. So getting a good history about what's been going on with the patient, preferably from someone who's knowledgeable about their 24/7, 365 types of activities. We do some neuropsychological testing, and then we're looking for these particular elements in yellow below, with a particular focus for today's audience in terms of the last two, the impaired reasoning and handling of complex tasks, poor judgment, changes in personality and their usual character, what their motivation is like, and their ability or inability to take initiative. Those are the things that we're listening for. When we talk about the parts of the brain, FTD tells us what we need to know. So frontal and temporal lobes are what we're focusing on. So here we have the frontal lobe. This is what we talk about when people have a filter or a lack thereof, but it's also how people interact with the world around them. So it's their inner self interacting with their environment. So this is when you're kind of your social skills, your emotionality, all kind of part of this frontal lobe function. Right below it is the temporal lobe. Most often we think about this as a language center, but it's not just about the spoken word or the written word. It's also about understanding instructions, so the hearing component, and in particular, we think about short-term memory centers being in this part of the brain. So let's talk about frontotemporal degeneration as from the clinical perspective. What I mean by this is what does a person look like when they come to me in clinic? How do I start stratifying them or assessing them? What are the kind of bins that I'm thinking about? So the one that we'll focus on mostly today is the first one. So what used to be called Pick's disease, named after Dr. Pick, who was a contemporary of Dr. Alzheimer, now more recently called Behavioral Variant or bvFTD. That is the lion's share of the frontotemporal degeneration that's out there. These are folks who, as you may already know, have florid personality changes, tend not to have insight into what their behavior is, how it's changed, how it's impacting others around them. They're often no longer socially appropriate. They can be what we call hyperoral, meaning that they don't really know hunger or fullness, so they kind of continue to eat even well beyond a good portion size. They can have disinhibited behaviors when out in public. They may have difficulties with their language, which I'll go into in a little bit more. And most often their memory is spared. When I say that, it doesn't mean that memory isn't ever affected. It's just not usually a cardinal feature. Moving on in this umbrella of frontotemporal degeneration are the primary progressive aphasias. So a lot of words there, but primary meaning the main issue is a progressive issue with one's language. So both the understanding of language and the speaking of language. So there's appropriately two subtypes underneath this. There's a non-fluent problem. So that's the non-fluent version of primary progressive aphasia, variant, if you will. So these are folks who, looking at a picture, may say boy, ball, kick, kind of losing a lot of the connecty words. They may spell words circle as C-I-R-C-U-L, for instance. Then the other major language subtype is semantic dementia, or semantic variant, SVPPA. And these are folks who have an abundance of language. They're quite fluent, but they don't really say a whole lot. Some people will say gibberish. The preferred term is word salad. They are saying things, but they've kind of lost the connection between, you ask them to point to a screwdriver, they point to a spoon. You ask them to point to a spoon, and they point to some grapes. So there isn't really a connection of what the word means and what the object stands for. And these folks can have a little bit more of that Alzheimer's flavor in terms of eventually developing some memory changes later on. But of course, as our title of our talk indicates, we will be focusing on behavioral variant FTD today. I present this slide as a compare and contrast. So many people think that dementia, the first thing that comes to mind is Alzheimer's disease. So let's make sure that we, again, make a good compare and contrast here. So when we think about frontotemporal dementia, we're thinking of a behavioral syndrome, where the major 3, 4, 5 symptoms that anybody may come to me in clinic with is a concern about someone's disinhibition, their apathy, lack of motivation, not quote unquote getting it, emotionally being blunted, being more OCD. It's not to say that they don't have cognitive issues as well, but when you look at these two columns, what you see is the preponderance of the evidence, the majority of the symptoms fall under behavioral problems. So when we start talking about the demographics more specifically now within frontotemporal degeneration of bvFTD. So we think about FTD as the second most frequent cause of early onset dementia after Alzheimer's disease, meaning that early onset doesn't mean mild symptoms. Early onset specifically refers to under the age of 65. It's an age cutoff only. And we often hear that bvFTD is only considered then or mostly considered then. And the fact is it still runs a fast second to Alzheimer's disease, even in that younger age range. Of course, should be thought about in that patient population, that age range. We don't see a difference in gender. So in Alzheimer's disease, you often hear this predilection for women over men. We don't see that in FTD. The onset is quite a bit broader. So we have a lot of younger folks, 35 to 75 in this age, in this grouping. And that has different impacts, as you may well imagine. So these are folks who are perhaps the sandwich generation. They are taking care of their elder parents, they have children in school, they themselves are gainfully employed, or quite honestly are maybe having difficulty remaining gainfully employed as a result of their symptoms. The duration of the disease, these numbers keep fluctuating, but we quote 5 to 10 years. I'll say why they're fluctuating. I think we're getting better and better as time goes on in identifying those earliest symptoms. When I see folks in clinic, I can usually dial back the clock and wonder about things that had been written off as being perhaps psychiatric issues, midlife crises, difficulties with a new boss. And that probably was the beginning of these symptoms in bvFTD. We now understand that bvFTD is another one of these spectrum disorders. So it is part and parcel sometimes with motor neuron disease. In the US, we most often call that Lou Gehrig's disease or ALS. Because of the nature of ALS, being a motor neuron disease and affecting people's breathing and movements, that tends to lead the charge when it comes to the duration of disease. So if one has those symptoms, their course will be quite a bit more accelerated. That does, want to be careful, that does not mean that every person with bvFTD will get ALS. In fact, it's still a minority of folks, but it's something we have to be, as clinicians and physicians, be much more aware of than we used to be. And it turns out that if you ask the right questions, we hear about a positive family history about 20 to 40% of the time. We talk about bvFTD mostly being a sporadic disease, that meaning anybody can get it without a family history, not necessarily a genetic component to it. But if you ask the right questions, and what do I mean by that? Well, it harkens back to that concept of spectrum disorders. So if you ask the question about being memory problems only, it may not capture everybody in the family. If you ask about folks who've had a variety of psychiatric diagnoses, maybe bipolar, manic, things that we may reframe as being behavioral variant, you start having a much larger encashment area. And if we ask about people who've had some Parkinson's disease or problems with their muscles, you can see how that would continue to broaden the capture of the family history. Additional features of FTD, so we talk about most dementias being insidious in onset and gradual in progression. It's not a you wake up one fine morning type of thing. In bvFTD, very characteristically, we see a decline in social interpersonal conduct, emotional blunting. These are things we'll hear from the caregivers often saying, you know, he's not the guy I married. That is not a Mars Venus thing. That is not a growing apart as a part of a married couple thing. That is something fundamentally has changed about the patient. And they typically lose insight. They don't understand that they're perhaps saying hurtful things to those around them. In the bottom half of the screen, we see some of the other things that happen that become more of an issue on a day-to-day basis. One's hygiene and grooming, becoming pretty rigid and inflexible, kind of goes with the OCD, having to do things a certain way. Dietary changes, you hear sometimes in the popular press, and this is a finding, that people with bvFTD have a preference for carbohydrates, so sugary foods. Again, not just as someone's getting older and having a preference for them, but really kind of shifting gears and going to the store and only buying sweets, so forth. So these are the couple of things I've already mentioned in the earlier slides, but kind of putting it together in terms of when we see somebody in clinic, what we're listening for. So we hear about the history part, the history of present illness. We're listening for things like the impulsive actions, the social inappropriateness, their apathy, lack of empathy, the dietary changes. Those are kind of things we're listening for. As part of our evaluation, we'll do some psychometric testing. These are paper and pencil tests most often in a clinic setting, if not working with a neuropsychologist. And we're looking for things, again, that map to those symptoms. So executive function, right? So knowing that C comes after B comes after A, that sequencing of actions. And typically they're not having problems with episodic memory, which is a type of memory that we see affected very early in Alzheimer's disease. So again, we're trying to winnow things down and make sure that what we're seeing, the person we're seeing doesn't have Alzheimer's. And if you get a couple of these categories met, then 3 out of these 6 criteria, then we'll say someone has possible bvFTD. What helps cinch it, of course, is if there's imaging available, MRIs, CAT scans, usually MRIs and PET scans. I'll show you some of those in a few moments. Then we can up the percentages to saying probable bvFTD. So this is what an MRI can look like of a person with bvFTD. Be pretty striking, and I'll kind of use the pointer here to point a few things out. This is a side view of the brain. So moving from the back to front, this is where visual information is. It's kind of the same orientation as the cartoon I showed you earlier. As we move forward in the brain, we see these gaps becoming wider and wider and wider, being the widest in the frontal lobes. So that's what bvFTD can look like to us in an MRI. This is somebody where it's an elevator view of their brain, so going from the neck up to the top of their head. And then here you can kind of draw a line all the way across, above which you can see that this brain should have gone all the way out to this dark line here, and it's kind of shrunken back from there or atrophied. This is a higher view of the brain, so just keep going up a few more floors in the elevator. And again, further back looks pretty okay. We see just much bigger spaces up front. Again, these are now the temporal lobes here. Lest you think sometimes when we do these presentations, we give you the perfect pictures. What about a real patient that we've seen in clinic recently? So here's, again, the elevator view, and I'm going to show you a couple pictures here. So let's focus in on this area that's in the orange circle. So that is the person's right temporal lobe. You'll see it's a difference from the other side. So they've had atrophy or brain shrinkage of the right temporal lobe. So this kind of what we call focal atrophy, so just a spot of atrophy, is what we more expect to see in bvFTD. And off to the right is looking at someone straight on, looking at that same part of the brain, so that right temporal lobe, getting compared to the left, and you see that there's more black space. So the skull has room for 2 things, brain and spinal fluid. So when we see more of the spinal fluid, which is white on the left and black on the right, that means there's been some shrinkage of the brain around that area. We have new tools nowadays to use to help us diagnose bvFTD. Turns out that Medicare and Medicaid will cover this particular kind of PET imaging if the question is Alzheimer's disease versus FTD. So here's a pristine picture once again. looking at FDG PET. Here, think of it as a heat sink map or a weather map. So areas of high brain activity are in your yellows and oranges, and underutilized areas are in blue. So if you kind of go all the way across, you can start drawing a line all the way through, above which it's more blue, below which is even down here where you see the redness. Okay? So these upper areas are the frontal lobes, and as we get down deeper, these are the temporal lobes. So another tool that we have in addition to the MRI I just showed you. Again, since we have a recent patient, I can show you similar things. This is a PET scan that we did on one of our more recent patients. And here you can see, again, we can draw this line all the way across where the temporal lobes are quite quiet. The rest of the brain seems to be reasonably active behind there. This is the same patient looking at them straight on. Sometimes it's a little bit easier to see. The temporal lobes hang out down here. So again, there's a pretty clear demarcation across the way here, above which we see good brain activity, below which we're seeing less activity. All right, so that's quite a bit to take on. We kind of introduced some terminology that we can all use and be on the same page about, where bvFTD falls in under frontotemporal degeneration, and some of the tools we have available currently to help make these assessments. I think we can take a few questions now.
Great, thank you. So in keeping with the idea that you've been speaking about making a diagnosis based on clinical presentation, there are a couple of questions. One is if you could define utilization behavior from the standpoint of a symptom that would be considered in diagnosis.
Yep. So utilization behavior often will ask about one having difficulty using utensils. It's probably the easiest way to think about it. So either making, not using a fork and a knife and spoon correctly, or making a mess in doing so. I think it's probably a concrete example of utilization behavior.
And thank you. So a couple questions about imaging. And I know that people appreciate the importance of imaging now, brain imaging, in helping to make this diagnosis. So one of the things that folks are wondering about is if the MRI doesn't show any atrophy, does that mean that the person would be in the early stages of the disease, or is there something else that might be going on?
That's a fair question. So I think if clinically the story lends itself to bvFTD, and I see a very normal brain MRI, it does cause me to pause about what else may be going on. And do we need to consider psychiatric diagnoses, which are the most common other also ran that we're usually trying to debate between the bvFTD and like a primary bipolar disorder, let's say. If I'm so compelled and the concern is there clinically for bvFTD, I think we then up the ante. I'll talk more about these, but whether we do spinal fluid testing or more imaging up at the PET imaging to help kind of add additional evidence in on one side or the other.
So an MRI might not show atrophy, but a PET might show a decrease in brain activity.
Correct.
Yeah, okay. And then the other question was really of the slides that you were showing with the MRI scans, how far advanced in progression would you say that patient is from kind of a clinical or a functional standpoint?
Yep. So the person for whom I showed you the PET scan, she does quite well. She's still driving. She does a number of her activities of daily life on her own. Admittedly, she thinks she's doing better than she really is. Unfortunately, in this age range, it turns out it's her mother and her stepfather who are caregivers who live a few blocks away and are actually, when you talk to them, doing quite a bit more for her, but she has some semblance of independence, understands it's hard for her to hold a job, and she's kind of gone through a few jobs recently, even temporary types of things. But, you know, if you met her in clinic, just in the waiting room, you wouldn't necessarily think anything was particularly, that she was necessarily the patient.
So is there a clear correlation between the amount of atrophy and the level of functioning, or is that variable from person to person?
It can be variable from person to person, but I would say that, you know, in the person I just described, she may not have that much, you know, profound atrophy of the type I showed you in some of the earlier MRIs. So we do, I would say most clinicians do have something in mind when they're looking at those MRIs of how much atrophy they would expect. Probably now have a few patients, 2 or 3 that come to mind, who have an MRI that looks quite good. We're quite convinced clinically they have bvFTD, and their PET scans are pending. So you could be on the, I would say they've kind of declared themselves clinically to be bvFTD. We just haven't quite found them what we call biomarker, whether that's an MRI or PET scan or spinal fluid to kind of match up with that yet.
So in terms of being able to make a diagnosis of possible or probable bvFTD, where would that scenario fall? Because I know sometimes we talk to folks on the helpline who are in a period of great frustration where the clinical signs and symptoms are there, the imaging evidence isn't there, and getting a diagnosis is hard.
So they would still be, they would qualify at that point to be possible bvFTD, because the distinction between possible to probable is the surety of the MRI, the imaging findings. So that should still be helpful. I understand the frustration, but it should still help in terms of pursuing the additional testing, saying, well, at least we think they've got a possible bvFTD. It's worth doing these additional tests, or pursuing centers or specialty centers that have expertise in kind of navigating that territory. I can't say that doing the FDG PET, like I showed you, is easy to do. There are, like I said, the insurance companies, there's a very strict criteria under which they allow us to order those and have those covered for you. So that may not be at that point your primary care physician, or maybe even your general neurologist. You may need to seek out a specialist to be able to do that next tier of testing.
But that does actually underlie one of the questions that also came in, was how important is it to get imaging to confirm a diagnosis? And that really is the difference between possible and probable, would
Correct.
be evidence from imaging.
Correct.
Great. Thank you. All right. We have other questions. I'm going to ask you to move along, and we will come back to what we can at the end.
Alrighty. So we just spent time talking about the clinical side of things in terms of what a patient looks like when they come into your clinic. I'm going to switch gears and redefine this from a molecular pathology standpoint. Now, I know you're worried that I'm a scientist, that PhD is going to come out to play, but I promise you there's a point to the method to this madness. So we look at the disorders now a little bit differently in terms of what's going on at the brain at the end of the day. What are those changes that are underlying these clinical features? So nothing to memorize, just kind of bear with me as we go through this. But this is how we now think about FTD, so frontotemporal degeneration broadly, and bvFTD among them. We now know that pretty much every form of FTD has a protein that has gone awry in some way. That's the cause of it, the root cause of it. In blue, you see those that are due to a protein called tau that I'll spend a lot more time talking about in a little bit. In green is TDP43. This is a protein that's supposed to live in the nucleus of the cell, the center of the cell, and managed to get into the wrong place at the wrong time. Phos in red is a similar type of protein and similar changes in disease. And the ones that you see kind of written vertically off the side are you can see the percentage as well. There are very small percentages of FTD that are explained away by that. So this actually helps us approach a disease a little bit differently. So now we're not so focused on what the patient looks like when they're coming in through the door, but rather what changes may be going on in their individual brain cells. Just to highlight, though, a lot of this is brand spanking new. We didn't know about the tau and the tau gene and its mutations until 1998. Progranulins, so this one was identified in 2006, TDP in 2008, FUS in 2009, CHIMP2B in 10, and C9 in 2011. So in the grand scheme of things, when you think about Dr. Alzheimer and Alzheimer's disease being identified in the early 1900s, we are a much younger field, although we've benefited greatly from the advances in the Alzheimer's field. But just kind of keep this in mind that a lot's gone on in a very short period of time in our field. So you'll say, Dr. G, you just explained the clinical presentation, you now told me about a bunch of these molecules. What does that have to do with us at the end of the day? Well, so it turns out that knowing the proteins is very, very helpful. It's helping us develop even more tools. So what do we do with those folks who are still waiting on their imaging or have imaging that's inconclusive? What other tools can we have? So wouldn't it be nice if we could have one of these malfunctioning proteins that we could measure in the spinal fluid or in their blood as another way of assessing what disease someone might have? Some of this actually already exists. So you see here mentioned TDP43. Turns out progranulin, for instance, if someone has a mutation in that gene, they actually have lower levels of that protein in their spinal fluid and in their blood. Not yet kind of ready for prime time testing yet, but kind of in development. A version of this, I will harken back to what's available in Alzheimer's disease just to make this point. So we already have some of this available commercially. So we can look at the tau protein and amyloid protein in spinal fluid, and that can aid us in making a diagnosis for Alzheimer's disease. You'll say, why am I bringing this up in this talk? Well, so often, as I mentioned, under the age of 65, bvFTD is still running a second to Alzheimer's disease. We need to often exclude that Alzheimer's disease is what's really going on. So it's important we can do this kind of spinal fluid test. It tells us yay or nay for Alzheimer's disease. If nay, then it's another kind of step forward in the bvFTD line of thought. But this is the kind of data we get back from this company. It takes about a month to turn around the results, but it's helpful. It helps us communicate with family as well about what may be going on. But all born out of the fact that we're measuring those proteins that have gone awry in the disease. There are now different kind of PET imaging. So the one I showed you so far has to do with high use, low use areas of the brain. We can actually look in a different kind of PET imaging for whether the misbehaving proteins are there. So we now have ability to do that with amyloid protein, again in Alzheimer's disease. You can look at the pictures up top. On the left side of the image here are the PET scans. Again, here, hot areas mean bad protein. And when these individuals have gone on to autopsy, we can see it kind of matches up pretty nicely with how much of the bad protein is present. So again, this is born out of understanding which proteins are malfunctioning. So tau, if you recall, is one of the proteins we look for, not just in Alzheimer's disease, but also in bvFTD. And here's what the different pictures can look like and different information we can get. There's Alzheimer's disease, CBD, and PSP are in another spectrum of FTD disorders as well. But we can start getting some additional information from looking for the malfunctioning tau protein and where it sits. You can imagine a day that we can do this with both proteins. So you have one injection, you get a picture for tau, and you get a picture for amyloid. And going from left to right, we have someone who's pretty normal clinically, and going all the way to the right, someone who's more affected, and you can see the pictures that help line up along those lines. So more tools that are being developed out of the fact that we better understand which molecules, which proteins are malfunctioning in these disorders. So back to the topic at hand, bvFTD. So what's coming down the pipeline for bvFTD? Because of that hierarchy kind of organizational plan I showed you of those molecules that are involved in bvFTD, we're able to think a little bit more intelligently, a little bit more thoughtfully about those proteins in particular. So I showed you some tau PET images looking for the malfunctioning tau protein in Alzheimer's disease brain. So there's a group of those, these four that I've listed here. But they were developed and designed to see tau in the context of Alzheimer's disease. Turns out all tau is not the same, and that the tau in bvFTD may look very different. So we need to screen the ones, these tracers, we call them, in the FTD population to see if we're going to get a good readout there or not. So it's a place to start. These tools exist in the Alzheimer's field. Let's see if we can port them over in FTD. We're also not just stopping there, but looking at additional targets, additional ways of looking at the FTD-specific kind of tau. And those are that next tier there, those three, that have already been looking more promising in FTD and related disorders that are not Alzheimer's disease. Tau has a few other special features to it that it can get as a protein gets modified by this thing called GSK3 beta. So how about if we can look at the modifier, right? So not looking for tau, but the thing that helps modify the tau into the malfunctioning form. So it's really important to develop these tools so we can A, help identify the disease, diagnose the disease, make sure that when we have clinical trials that we're enrolling the right people and making sure that we can comment on whether a drug is useful or not, right? Is it actually getting to where it needs to go? Is it dealing with the malfunctioning proteins appropriately? So this is a slide current as of even last week. So more to come. Stay tuned. Because we now have this way of thinking about the proteins that are malfunctioning at the end of the day, there's new ways we're even approaching treatment, not just tracking the disease and diagnosing disease, but how about we make those proteins our targets? A lot of information on this slide. Don't want to overwhelm you. Again, pretty darn current stuff, and you'll always get your latest and greatest information from the FTD registry that's already been talked about, and I'll mention again in a little bit. But kind of groupings of things. So this is very tau protein based in this slide. So tau is thought to help stabilize the infrastructure, the superhighways of the brain cells, and that when it malfunctions, the highways go or become unstable. So how about if we develop drugs that help stabilize that system? Okay, so that's the first two, the TPI and then the divutinide. Divutinide, the second one is actually in studies right now for non-Alzheimer's tau diseases. How about we think about this tau protein that malfunctions seems to not just misbehave in one cell, it kind of spreads. So what if we develop an antibody that could keep that spread from happening? Well, that's that next bullet point with the BIIB and the BMS antibodies. So be it a vaccination type of thing, perhaps monthly infusions, we'd have to kind of figure out exactly what that would look like. But the idea, again, is going after this malfunctioning protein, keeping it from spreading. The tau protein, when it misbehaves, likes to glom onto itself and gum up the works. So how about if we attack that aggregated form, the mucking up form? That's what the ABB agent does. And then just one that doesn't quite fit in the category easily is oxytocin. This is a hormone our brain normally makes, but it is turned out that if you do take it intranasally, so like a Flonase or a little inhaler, twice a day, at least in bvFTD, it looks like it may be helpful with managing some behaviors in the social disinhibition. It's a twice-a-day spray that presents some challenges unto itself, but it's already moving into a phase 2 clinical trial to see if there's if this is a practicable and practicable treatment to offer. But again, this is hot off the presses, and in terms of what will be available to you anytime soon, these are still in development, still in trials, but the FTD registry will be your best source of information for kind of future attractions. All right, another opportunity to take some questions.
Great. So someone was asking, you had mentioned about the different advances in imaging that now allow us to rule out Alzheimer's disease and perhaps get a greater clarity on the diagnosis. The question is, can someone have both FTD and Alzheimer's at the same time?
That is a good question. I think traditionally we would say it's an either-or proposition. That is mostly born out of how kind of the criteria that we think of. We think about the earliest stages of each disease process. So arguably, say 5, 6, 7 years down into any of the dementias, there's a lot of overlapping features. There are some hallucinations, difficulties with language, behaviors that are no longer as they used to be. So we often focus on the first year or 2 or 3 of symptoms. And that's usually where things parse out. So if someone has bvFTD, we're listening for the behaviors and personality changes. In Alzheimer's disease, we're listening for the memory changes. So far, to my knowledge, we really think of them as separate things and not something someone could have together. We do see vascular dementia, so dementia due to strokes, co-occur. So someone can have had a stroke, go on to develop Alzheimer's, have a stroke, go on to develop bvFTD, and vice versa. But bvFTD and Alzheimer's together now.
And I think in your answer, what I heard that I think is an important point to underscore is the value of that history. So when people are reporting the history and trying to go back and figure out what were some of the earliest things that we noticed, that kind of information to the clinician is really important.
It is, and it's challenging on the part of the caregivers often because they're often very overwhelmed with what they're dealing with and want to make sure that the clinician knows everything about what's going on today and yesterday. And we're often, pushing them to dial the clock back. And what were those earliest symptoms? Sometimes I'll ask, if you had to put your nickel down, what was the first symptom? Was it a language thing, a behavior thing, or a memory thing? And really kind of force everybody in the room to kind of come to a consensus that, really it was a language thing or a behavior thing. Seems like a simple way to do it, but I think it really does help us get through the essentials.
Mm-hmm, mm-hmm. And a similar question in terms of the difference between clinical symptoms and pathology. And the question is around Pick's disease. So can you just speak to the term Pick's disease and how it is used currently? Yeah,
so Pick's disease has to do with Dr. Pick, Arnold Pick, who was what is now the Czech Republic, but Czechoslovakian at the time, pathologist. So this is what he saw in his patients under the microscope after they passed. So it's a particular form of the tau protein that is malfunctioned and malformed. Looks like a little ball under the microscope. That is called a Pick body. People who have that have Pick's disease. Now, when you see the person in clinic, you sure don't know what's going on in their neurons, right? You don't have a picture to see if they have Pick bodies in there, at least not yet. So that term we now think about the clinical terminology and the pathology as separate things. So we'll most often say a person clinically has bvFTD. They may have Pick's disease, autopsy.
And so a related question is that for those people who do go on to have brain donation or autopsy done after death, what's the correlation between the clinical diagnosis during life and the results in the autopsy upon death?
Yep. So that can be, we'd like to think it's 100%. I think we are constantly learning from these brain banks about how accurate and inaccurate we often are. So I had a caregiver who was actually one of the leads of one of our local AFTD caregiver groups. When their loved one passed, we found out they had Alzheimer's disease pathology in their frontal lobes. So acted for all the world like bvFTD, but it was Alzheimer's disease at the end of the day. And she was a little distraught, not sure what to make of her role anymore as a caregiver. And we chatted that this was the benefit of the brain donation in the first place, right? That we continue to learn how broad these disorders can be, and that her experience with her loved one was every bit as valuable still. So still learning how to take her loved one out in public and passing on those challenges and strategies on to other people in the caregiver group. So we're not, I think their numbers vary from center to center. We like to think we're doing a better and better job as time goes on of being clinically correct and then pathologically correct as well.
Great, thank you. Let's talk about how we get evaluated.
Okay, so a lot of tools out there, but how does one enter the pipeline, right? So this is what we do when we think about how our patients get evaluated. As I mentioned early on, in neurology, the battle is lost if you don't get a good history. I think that's come up a couple times so far for us. So we do a clinical assessment. So that's a patient and caregiver coming to clinic. We tip in our clinic, the patient is getting this second bullet point, some of the paper and pencil testing done at the time that we're talking to the caregiver, and getting a good idea of what an average day looks like, what tasks they can and can no longer do, so forth. Pretty detailed questions. And then we regroup with the patient and their test results and kind of bring that all together. So it'll be the history, their test results, a neurological exam that I'm going to get to in a moment as well. But back to the history piece, we're listening for some specific things, right? So here you'll hear about, Alzheimer's disease often is equated with dementia, but we're listening for things that get us off that path. So for frontotemporal degeneration, it's going to be the behaviors and language, and for bvFTD, the behaviors in particular that we're listening for as those cardinal put your nickel down types of symptoms. Well, then we talk about kind of what's no longer really advanced diagnostics. This is becoming more and more standard of care, where we'll talk about whether a spinal tap is indicated, whether MRI needs to be done. Spinal Tap I've already talked to you a little bit about, but this is how it can be helpful, at least saying, you know, we can be reasonably confident that the individual does not have early onset Alzheimer's disease. So Alzheimer's disease under the age of 65 can often look very much like bvFTD. It's worth figuring out if it's Alzheimer's or not. We do that with the spinal fluid testing. The MRI that I mentioned earlier, this is an individual of bvFTD, and this is the elevator view of the brain, so looking from high down to low. But you can already see that these crevices really should be about yay wide and are quite a bit broader. So this is a lot of the frontal lobe. And then you see one side more so than the other, so left more than right. These are flipped around. Again, left more than right. As we're coming on through, though, here's a temporal lobe. You see a lot of extra space on the right and a fair amount of space on the left, to be honest. Okay. So we can do the MRI, but we can now do even more with the MRI than we used to be able to do. So this is me eyeballing it, telling you what's more or less. We actually put some teeth to it and put some numbers to it. So we can basically put someone's brain on a growth chart. So remember when it's kiddos and you wonder if they're at the 80th percentile for height or the 60th percentile for weight, we now do that with brains as well. So the main line through center is the average thickness or size of each brain region we're interested in for a group of 50-year-olds here. First standard deviation is a little bit of buffer, a little wiggle room around that we would still find reasonably acceptable. And the blue lines are the 2 standard deviations. So that's still thought to be within a reasonable amount of normal, but I would say, you know, the percentiles kind of speak for themselves. For the person I just showed you, on the right side, they were, over time we saw them, so we had 3 points in time, 9th percentile, 6th percentile, 7th percentile for their right frontal and temporal lobes. So we can now kind of glean this additional information from a regular MRI. I mentioned the FDG PET, so this is just looking for high use, low use parts of brain. And the point of this slide is each dementia gives us a different pattern. So normally, lots of yellow and orange all the way through the brain. In Alzheimer's disease, we see certain parts of the brain quiet down earlier. So these are the parietal lobes that we'll see quiet down earlier. Lewy body dementia, these are folks who have visual hallucinations. You can actually see changes further back in the brain where that visual information is. Then here we have FTD, where we see those frontal and temporal lobes being a little bit quieter. This is a tool we can use in a real clinic setting now. This isn't just research grade. So you have your clinical evaluation. We talk about treatment. I'm going to start with medications, because I'm a physician, and that's kind of what our tools most often are. I will talk about non-medication treatment options as well, so just bear with me. It turns out that some subtypes of FTD, at the end of the day, can have Alzheimer's pathology, like the one case I mentioned. So it's not unreasonable, and several physicians will probably think about using the Alzheimer's medications, whether that's donepezil, galantamine, rivastigmine, or memantine. Should be known, though, that none of them have been shown to improve FTD, and at least one study I can think of has shown a detriment of behaviors on the donepezil type of medications. I think in the field that we are right now, where there aren't a lot of options, I think it's not unreasonable to try. If it offers benefit, great. If it doesn't offer detriment, then, you know, that's a different story. But this is, I think, not an uncommon approach. So then we kind of move into the symptoms. Let's talk about how we can support the patient and the caregiver. So it's understandable that a person can begin to feel depressed and frustrated. We think depression, at least in Alzheimer's disease, might be part and parcel of the disease process itself. So it may be appropriate to have SSRIs or SNRIs. So here are a couple of more common ones we'll use: citalopram, sertraline, or venlafaxine. Sometimes the behaviors in bvFTD can become difficult to diffuse or redirect, which is always preferable. And treatment with antipsychotics or other mood stabilizers may be indicated. So we'll often use medications like quetiapine, risperidone, valproate. Valproate is an anti-epileptic, but it's used in psychiatry for mood disorders, bipolar disorder, and here we would use it to quell behaviors as well. But it's not all about just the medications. So a lot of supportive measures we think about. If someone's having speech difficulties, so bvFTD doesn't mean you can't have language problems. The idea would be to harness the language that the patient still has intact and augment it moving forward. So we talk about augmentation strategies with speech therapists. You have to find speech therapists who kind of get it, that this isn't stroke-related language problems. You're not going to recover. It's only going to decline, but what can we do to give the person some tools? It can be something as like a laptop or a tablet. For those who are technologically a little bit more, find that difficult to take on, they can have a phrase book, just kind of picture book in their pocket. So when they want a banana, they can't say the word, they can flip to the page and point out what they want. But these strategies that speech therapists can help with. Certainly, I think in most of our dementia practices, we recognize that it's not usually just the patient who's the only patient in the room. We often have to think about the caregiver and their needs and their respite and support for them as well. So there's a growing appreciation. Sharon mentioned the AFTD support groups that are growing, and they're even growing in our community here. So recognizing that that's a need. Couple of strategies that I probably don't spend enough time talking about in clinic and don't always get a chance to, but we get to today. So this was an article a couple of years back now in 2009 about instead of saying X, try saying Y. And it's just kind of changing your dialogue as a caregiver with your loved one. A couple of different examples here. Let's take the middle column, saying, you know, get away from me, you're not my husband. And the immediate reaction being, I am your husband. And trying to redirect and correct and making you know, drawing a line in the sand about it. Or try saying, you must love your husband very much, and I can tell you by the way you talk about him and so forth. It's potentially much easier said than done, but I think it is a change in approach and a change in mentality, right, as a caregiver. And a lot of us will do this in clinic with the paper and pencil testing. Someone's getting very frustrated with how many quarters there are on $1.75, and they say 10, and you're like, right, and we move on, right? You don't challenge them, you don't correct them. You got the information you need, and you can move on. So I think this was a helpful script to embrace. Most recently, we heard about in our community, Project Present. So this is by Anne-Marie Moore, who's a former Second City troop trainee, and looking at improv skills to be harnessed in the caregiver situation. So here's a mission statement for them, and they, so far has been trialed in the Alzheimer's group in our community, but we very specifically asked about FTD to be broadened to FTD, this group. But really using the improv techniques to improve interpersonal connection, creative expression, and joyful collaboration. So it's kind of an even level playing field for both caregiver and patient, and where everyone's having to kind of stretch their minds differently. You meet where the care receiver, where they are, is their reality. You're often thinking outside the box, and it's not just in these workshops, but really being able to take those home as skills of like, how do you get your loved one to take the medications that they're refusing, or bathing when they don't want to, and are there ways that you can redirect and distract creatively? Some of the kind of skills and take-home points from such exercises. Got to give up control, slow down, making eye contact. Turns out that folks who aren't able to speak anymore, you can do quite a bit with body language. Be flexible, have a give and take. So these are avenues of now research and kind of support out there for caregivers. A couple more questions.
Great, thank you. Actually, there's a question about the oxytocin trial that you mentioned, which fits both with treatment and the research, in that you mentioned it in the context of possibly being helpful for controlling behavior. Are there benefits to that approach over the antipsychotics or other medications that are often used to help manage behaviors?
So I think the oxytocin is still very much in the early stages. It's only at a phase 2 trial, so there's phase 3 pending, and then where it would even become an option for a patient population. So it's very nascent, early in the stage of development. I think it does offer an interesting avenue. It is a hormone your body already makes, so it's not a toxin to the body. given intranasally, it tracks back through our smell nerves back to the brain, so it doesn't really get into the rest of your body. It can kind of go where the action is. So it's kind of a lot of things are attractive about it, but practically speaking, in the next, say, 2 to 3 years, it won't be a viable alternative for the antipsychotics. So I think the antipsychotics are here to stay for the moment.
And so a follow-up question, are of the new approaches to treatment that were mentioned, are there any medications that are new and currently being used to manage symptoms that have benefits over other things that have been used longer?
There have not. I think we're left with much the same arsenal that we always have. Like you said, the Alzheimer's medicines are often still tried. We look at the antidepressants, antipsychotics, mood stabilizers. Those are still kind of the same arsenal we've always had. I think in individual settings, there have been, I would say when we work with our community partners, there are memory care centers. There are now other regulations about what percentage of your population in a nursing home can be on antipsychotics. So there has been a move to look at the seizure medicines, right? So things like the valproate that I mentioned, lamotrigine. These are mood stabilizers that the psychiatric community certainly uses in that way. And I think they're more adopted in those longer-term care facility settings to avoid a high percentage of patients being on antipsychotics. I don't know that one group necessarily works better than the other, though.
Mm-hmm. And of the new research and, again, the new approaches to medications, how much of that is focused on symptomatic treatments versus treatments that would delay or slow the progression of the disease?
Yep, good question. So that is exactly where the field is, that we've recognized that we've often had clinical trials in folks who are quite affected, and you're really asking that medication to do a lot. A lot of changes already happened in the brain, and you're really trying to ask the medicine to bring someone back from the brink. So in fact, the field has changed towards not just symptomatic management, but earlier in disease, stopping the disease in its tracks, early detection, earliest symptoms, and ideally prevention as well. We're not quite there yet in our field. So that slide's worth of approaches really gets down to what's going wrong in the cell, in the brain at the brain cell level, and how do we stop it dead in its tracks? How do we clear out the malfunctioning protein? So it's not waiting. It's looking earlier and earlier in the disease process.
Thanks. A couple of questions related to the diagnostic evaluation. So at what point would a spinal tap be considered in the evaluation process?
Mm-hmm. So that's a tricky question even in St. Louis where I am. So we've had patients come and families go, hey, we've seen a neurologist, why didn't they think about a spinal tap sooner? And I had to say that other than our practice and one community practice I'm aware of, spinal taps aren't readily offered in an outpatient setting. So in a clinic setting where they're just, even though neurologists all know how to, have been trained on how to do them, many of them don't do them meaningfully moving forward in their practices. So it does create a bit of a glut. So it has to be a place that is comfortable doing them, comfortable offering them, does enough of them, so forth. So I would say if there was kind of a scenario that came up earlier, so we really think the person has bvFTD, the MRI doesn't yet show evidence of it, PET scan, the FDG PET is maybe not going to happen because insurance may or may not cover it. Spinal tap will almost always be covered in that setting. So I think we integrate it in our practice pretty early on, as would most academic centers, I would say. So I think this is where, going from a general neurologist to a specialty center would become more important.
Well, and that actually leads right into the next question, which is for those people who are not located near a clinic, and when traveling is really difficult, are there options or increasing options to be evaluated remotely via video conferencing, or is technology being incorporated at all for people who can't travel to those specialty centers?
Yep, excellent question. So telemedicine is definitely a growing field. Within neurology, we've probably seen it most in stroke. Dementia, I think, would be a handy other group to be able to expand into, and I tell you why. So, neurologists are very tactile. We want to be able to see our patients, read between the lines from what caregivers are and aren't telling us, and examining the patient. I would say that in our dementias, even though we do a good neurological exam, it's not usually the defining part of the evaluation unless we see some Parkinsonism or something that looks like ALS. So I think it would lend itself to that expansion. So far within neurology, telemedicine has really taken hold within the field of stroke and maybe even some ICU critical care. But I think the time for dementia is probably not too far off in the future.
Great, thank you. Is there any way to stop the deterioration of brain tissue once the disease has started?
We certainly like to think so. And I think that's the hope and the advice we always give, that we keep those connections that are there strong. So I'll say that folks aren't allowed in my clinic to become one with their Barca lounger. They're to remain physically active, cognitively active. You have to find those activities that work for you. Not everything's about a crossword puzzle or a word search, but if you are someone who has always been interested in learning a language for travel or want to take up photography, so it's really finding that thing that works for you. Also, we now know that heart healthy is being brain healthy, so kind of your middle-age weight predicts kind of future cognitive health. The same little blood vessels that get you in trouble with your heart get you in trouble with your brain. So kind of good general axioms of good health and good healthy living are all, we anticipate continue for good brain health as well.
Back to the idea of the clinical diagnosis. How often does a clinical diagnosis change over the course of the disease? So, for example, does someone with a PPA diagnosis morph into someone with a clinical diagnosis of behavioral FTD?
Good question. So in that particular example, PPA often will morph into Alzheimer's disease. So in those individuals, they have they secondarily develop a difficulty with their short-term memory and so forth. So yes, morphing is possible. I think that would be the easy answer. But understanding that the diagnosis is made based on the information at hand, and a patient is allowed to evolve as is the diagnosis.
So someone may have a clinical diagnosis early on that could change over time.
It could. I wouldn't say it's particularly common, but it could.
And is excessive daytime sleepiness a part of behavioral FTD, or is that a side effect of medication?
Potentially both. So the clearest example would be when it's due to medication. So those antipsychotics can certainly make people sleepy. The antidepressants, if given at nighttime instead of the morning, can actually be disruptive to sleep cycles. So it's not uncommon for me to switch people up and make sure they're taking those medications in the morning, where it can be a little bit of an upper instead of getting it to them at nighttime. We do worry about sleep disturbance more and more in dementia as a whole, not just even in bvFTD. Most often when we're thinking about it, we think about it in a group of disorders I didn't mention in particular, but more in the Parkinson's flavor. So whether it's Parkinson's disease, PSP, CBD, Lewy body dementia, that's where we usually now most think about sleep disturbance.
Couple questions related to diagnoses of a mental health disorder and or brain trauma. So can you just speak briefly to possible connections? Are there instances where someone diagnosed with a mental health disorder or someone who had brain trauma, when they develop, could those factors be part of developing behavioral FTD later on?
Yeah, so absolutely. We certainly take stock of that when we're doing our history taking about what I think again, the easiest answer on that one is the head trauma. There's so much more appreciation now about traumatic brain injury, chronic traumatic encephalopathy, which is what we're hearing among our football players. So how many concussions to the head where it's been lights out? What does that make you at greater risk for moving forward? And basically, any of the dementias are at greater risk moving forward. It's not just Alzheimer's disease, FTD, ALS, Parkinson's, all of them. You're at greater risk moving forward. So we do take that into account. The mental health disorder one is trickier by far because bvFTD so often looks psychiatric at the beginning. It's not uncommon for people to have those diagnoses when they come to me. But you have to think about it a little bit. So not particularly likely to have new onset bipolar or new onset schizophrenia at age 50 plus. It's not impossible, but it's not particularly likely that the first-time schizophrenic didn't have, classically that first year in college is their first psychotic break. So for them to be in their 50s and having that first-time episode would cause me to pause. I've now had a couple of schizophrenics I've seen recently, one of whom we did do all this advanced testing, spinal fluid and the FDG PET, and he looks like he had FTD as well. And that was from a very astute psychiatrist who says, he's having problems more than I can explain from his well-controlled schizophrenia alone. And that was the prompt to kind of do the deeper dive in him. So again, not particularly common.
And there's a question about some therapies that are being introduced, and I know done in research to some extent in PPA, that are using electrical current, direct current. Can you comment on those therapies and that research a little bit? Yeah,
so a transcranial TCM, I have to think about this. TCD, that's what it is. Emerging field, I think, so I know one group in town is doing that. I think more to be seen, more to be learned. Makes a little bit of sense, right? So we have networks of activity in our brain, and something has gone awry with the wiring, and can we reset that in any way? So I think that is it is research grade, it's not yet FDA approved to my knowledge, so more to be seen. Again, thinking outside the box in terms of other ways to approach the problem. We're open to it. We want to see the good data for it, though, to make sure it's safe and robust to be able to offer our patients.
And while the question came in separately, it seems like it may be related in some ways. It is neuroplasticity relevant in something like that, and or other aspects of treatment or rehab that are being used?
Yeah, so neuroplasticity is kind of brain agility. And so the more agile, so we do see, for instance, what we call cognitive reserve. So those individuals who've either had higher levels of formal education or even work experience education seem to be more resilient. So we look at their brains, we see a lot of brain shrinkage, yet they're doing pretty darn well day to day. And what's the buffer? The buffer, we think, has to do with their training / education. I don't want to make it sound like it's years of school only. So on-the-job training is every bit as important. So that had been an earlier question, can you see from the amount of brain shrinkage what their symptoms ought to be? So this is usually the person who's doing far better than their imaging would suggest. And we think that has to do with just they have a deeper reserve to pull from.
And one last question related to the search for a diagnosis and evaluation process. Who are the best people for doctor? What type of doctor is the best person for folks to look for? And also with the role of mental health diagnoses and misdiagnoses in the mental health world, what's the crossover like between the cognitive neurologists, the psychiatrists, and the neurologists in terms of an evaluation process?
Yeah, so I'm a neurologist, but you'll see that I'm also have an appointment in psychiatry, so I kind of bridge both worlds here. I think when the matter of a non-Alzheimer's dementia comes up, I think seeing a neurologist, one, and then a cognitive neurologist potentially thereafter becomes relevant. When it comes to dementia diagnoses overall, it's amusing when I meet with my psychiatry buddies, because they're like, what do you mean you diagnose dementia? We diagnose dementia. So it really falls under both hats. In fact, in my clinic, I always have a psychiatry resident training with me for that very reason, because there is so much crosstalk and there needs to be more cross-training as well. So you don't get misdiagnosed because you went to one kind of doctor versus the other. So I think starting with your primary and going to a neurologist, if something seems a little bit not quite characteristic Alzheimer's disease, going down the cognitive neurology route. But to be fair, when some of these behaviors need to be managed in bvFTD, I certainly call on my geriatric psychiatry colleagues to help me manage them, because the medications are things that they're far more comfortable with, the dosing and so forth, than I may be. So if the disorders are a spectrum disorder, then you might need a spectrum of doctors as well.
Great, thanks. All right, let's move on.
Okay, so I think we're in the last section or so. So great, Doc, you told us a lot of stuff. So how do I get my hands dirty, right? How do I get into it? So how do we get involved with research? So in the last year 4 now, we have these consortia. So 2 groups, Artful and Lefties. I don't come up with the names, I just report on them. But these are large medical centers that have banded together, because at the end of the day, bvFTD and the FTDs in general are a smaller percentage of all the dementia out there. So it's probably not going to be any one center that is going to move the field forward. So we've banded together and making these 2 consortia. Just geographically, this is where the centers are. The 2 studies are very complementary, and I'll go into a little bit of details of those. But you can get resources, get evaluation, at any one of these centers. And we have 2 more coming online as well. One's going to be in Nevada, and I think a second one in Texas. But lefties, so in this study, you have to have a hereditary form of FTD, so a known gene in the family that's affected. Each individual does not need to know whether they are carrying the mutation or not. We are now finishing up year 4, going into year 5 of this study. People come in for pretty comprehensive several-day evaluations. So it's all about that clinical, right? So good history taking, doing the paper and pencil testing, good high-grade MRI, blood tests, and spinal fluid testing. Okay, that's the ask. People come back a couple times, preferably on the year, but thereabouts. And so we can see so we can learn what the diseases are, what they look like over a couple-year period of time, develop these targets, know what things we're going to need to move and change with drugs and clinical trials moving forward. But this is for inherited forms of FTD. Artful is, so kind of compare and contrast the 2 studies here. So both of the studies are interested in FTD, frontotemporal degeneration. The lefties ones are in inherited forms. These are folks that we see over time. Artful is broader because it's all-encompassing, all sporadic types, no family history types, bvFTD more included in this group, and it's the one that's the most geared towards developing clinical trials. Okay. Just a couple of highlights. So as of when I made this slide a little while ago, we're over 1,000 participants across both studies. Always looking to enroll. You can see in Artful we're a little bit behind. So this is where bvFTD would come in under Project 1. So always interested in having more recruits. The ask there is a little bit less, typically 1 or maybe 2 visits over a year. Tools that were developed as a result of these 2 studies includes the FTD registry that you've heard a couple of times now, as mentioned, where you can become part of the registry. You can learn more about what's out there. As clinical trials become available, they'll be available through the site as well. But as you can see, definitely bvFTD is welcome to join the registry. Unless you wonder that, well, you're talking about inherited forms of FTD, and what does that have to do with, non-family versions of FTD? So we already have some data from this group saying that while our sporadic bvFTD folks tend to be older on average than the folks who have the inherited forms, they track exactly the same. So all the tools that we're developing in lefties are going to be absolutely applicable to folks in the general public. And I think that was an important thing for us to be able to determine. I think at some gut level we thought that was going to be the case, but we now have the data that backs that up. So these efforts are going to help the broader bvFTD community as a whole. Sharon, do you want to take a break here or finish this last section out?
I would say finish this, and then we'll have a good chunk of time for questions at the end.
I like it. So this comes up quite often in clinic and in other discussions about what about genetic testing? Should I get it done? I hear there's inherited forms, so forth. So let's talk through a slide or 2 about that. So there are quite a few considerations when talks about genetic testing. For instance, who should be tested? So we're usually looking for a really strong family history. These genes I had in that one diagram are all dominantly inherited, meaning that there should be an affected person in each generation of the family. and we're usually looking for 3 generations to make that determination. You have to ask yourself why it is that you want to be tested. Just to know, admittedly, knowledge is power, sure. Is it going to impact your family planning? So there's now in utero testing that can be done, and selecting embryos that do not have the mutation, fraught with ethics and personal preferences for sure, but is that what your angle is? And not yet does it affect or change your treatment options. We're still talking about that same arsenal. Now, I think in the next 5 years or so, knowing your genetic status may very well change what drugs are offered to you or studies that are offered to you prior to that. But we're not quite there yet. So it's not clear what finding out does for you. And because it's dominantly inherited, these diseases, it's not just you finding out for yourself. It actually tells you your SIBs. If you're the first person, then that means if you have the mutation, then it informs what happens to your kids and informs what your siblings may want to know about. And we're back in this world of pre-existing conditions now. So have to think about what this means about entering your medical record. As a result of all these considerations, we recommend pursuing genetic counseling to answer these questions before you ever move forward with genetic testing. So the studies I just mentioned are for lefties, and lefties in particular, we have that avenue of support. So provide you with genetic counseling, and basically you can do everything and stop short of getting tested. So you provide all the resources, the counseling, and you can decide at the end of the entire process, you know what, I'm not ready to find out. This is a family tree of what a family with bvFTD that was genetic in their case. So anybody with a black box or half the black box is somebody who was affected. And you can see there's actually 4 generations here of affected individuals. So if someone came to you from this family, had some symptoms that we're concerned about, it would be far more compelling to kind of pursue the genetic testing for them. A couple of useful websites. Of course, our biggest source of support is the AFTD. In our community, the Alzheimer's Association has been pretty helpful. They are not restricted just to the Alzheimer's disease. They're used to seeing folks with earlier onset diseases, and so we rely on them a fair amount as well. And then finally, kind of resources here at WashU. So we have our NIGHT ADRC. Again, while AD, Alzheimer's disease, is part of the name, kind of a conduit to research. And then our faculty clinic, where we see outpatient memory concerned folks, is our Memory Diagnostics Center. All right, I think that wraps that part up.
Great, thank you. So these are your last slides, right?
Yep, I think I just said that, but here you go.
Okay, so we have about 12 minutes, and we'll try to cover as many questions as we can. Some may jump around a bit, so it'll be a little bit of test of your mental flexibility.
My neuronal plasticity, okay.
If there's slides you want to go back to, of course, you can do that if that's helpful in any way. So one person's asking, if you already know that you have the C9 gene, like mutation in the family, and there's a history of bvFTD, when would be the best time to schedule a clinic appointment?
Very good question. So in that case, before these studies were available, I would say do not worry until there's a symptom that prompts concern. But because we now have lefties, we're interested in folks who are even from a family where you don't yet have to have symptoms. It would be appropriate to approach one of the sites if you were interested in the research and being enrolled. Otherwise, we typically say if you don't have a symptom, don't worry about it just yet.
And being part of the research, is there an advantage for families who are when it comes time for drugs to reach the clinical trial stage?
Yeah, so we always say the clinical trial, that being in research studies affords greater contact with the experts, being on the short list for studies and trials, picking up on things earlier. So instead of an annual visit with your primary care physician, you're probably being seen a few more times through these research studies. That being said, now that we have the FTD registry, it certainly wouldn't preclude you from being called upon for clinical trials if you weren't able to enroll in one of the other main studies. So I do want to kind of be careful about saying you have to be at an academic center and enrolled in one of those bigger studies. The FTD registry will afford the bigger kind of encatchment area that way.
Great, thanks. I wanted to mention too, in terms of the whole question of the genetics of FTD and genetic counseling, that our just prior webinar in this series in March was all about the genetics of FTD. And so our closing slide will have a link to where those webinars are archived. So if this is a particular area of interest, I would encourage you to look that one up and see if it's helpful. So there's a question about similarities between Parkinson's and behavioral FTD. Can you speak to that for a moment?
Sure. So I mentioned spectrum disorders, so certainly there are those with FTD who can have some Parkinsonism, so not full-on Parkinson's disease, but some elements of Parkinson's disease. In fact, that was the first genetic form that was identified. It was FTD-P17, so frontotemporal degeneration, Parkinsonism on chromosome 17, long name. So recognizing that that's part and parcel of this spectrum of disorders. Where I think this question may be going, though, is if someone has Parkinson's disease and they have impulsivity and some of these bvFTD type features, I'd be a little careful because that can be common as a result of the medications that Parkinson's patients take. So a third or so of Parkinson's patients will develop a dementia that's more Alzheimer's-like. So if we're looking at some of these impulsivity types of things, it can be a very direct connection to the medications they're on.
Great, thank you. There were a couple of questions about repetitive behaviors as one of the symptoms that happens in FTD. How do you deal with them?
Yeah, it can be tough if redirection. So I had a gentleman who could spend all day long getting a coffee mug just so in front of him and literally making very small movements, you know, moving around not even a centimeter at a time. So we can kind of think about that as an OCD type characteristic and treat it as such, in which case those SSRIs or those antidepressants can be helpful really to treat that behavior.
I would also point people to the Partners in FTD Care series of newsletters. We have done a number of topics which try to offer some really practical suggestions that people can use in the home and strategies, the environmental behavioral strategies. And there is an issue that speaks to the repetitive behaviors, and there might be some tips there that people would be interested in. You can find them on our website too.
Perfect.
Can you speak a little bit to your opinion about using ALS medications for people with FTD ALS?
The ALS medications have been shown to provide some very modest benefit in ALS, and the disease isn't actually that different than in FTD ALS. So I think it's reasonable to certainly offer that population the similar drug.
Thank you. And a question about posterior cortical atrophy. Do you often see posterior cortical atrophy in behavioral FTD patients?
So typically do not. So posterior cortical variant is atrophy on the opposite side of the brain, so the back side of the brain, as opposed to bvFTD. Those individuals can have visual type symptoms, so visual hallucinations, depth perception issues, difficulties with calculations, among other things. So just it kind of feels very different than bvFTD. I do have one C9 patient. When I looked at her MRI, she had posterior cortical changes, and it's a strong family history. She presented with ALS first, and I did have to do a double take when I saw her MRI. So never say never, but it quite literally is the other half of the brain that's affected in posterior cortical dysfunction.
Thank you. Are there symptoms that are more typical to a hereditary type of FTD and symptoms that are more typical to sporadic FTD?
Not that comes to mind. So what we think of with the hereditary forms is that they're earlier in onset and maybe a little bit more aggressive, but really the complement symptoms are pretty much the same.
And so just to clarify, when you say aggressive, that's the disease itself is aggressive and not necessarily symptoms of aggression. Yeah,
right.
okay.
Correct. Fair, thank you. Progression of the disease, not as a behavior.
And can you just go back to Artful and describe the difference between Artful 1 and Artful 2?
Sure. Let's actually pull up that slide. Maybe. Did I have it? Might not have done. Okay, thought it separated up. I do on the enrollment, don't I? There we go. So project 1 is all comers, sporadic frontotemporal degeneration of all types. The bvFTD, the language variants, the Parkinsonian variants, the ALS variants, all of them can come in under Artful Project 1. If you are affected or not determines how many visits you may have. Project 2, there needs to be a hereditary component. You don't have to know the gene in that case. You just have to have a strong family history of the kind of family tree that I provided. So that's the big difference between 1 and 2, sporadic versus hereditary.
The testing protocol is the same in both of those projects?
They very much are, yes.
Yeah. Okay, thanks.
Mm-hmm.
Another question about evaluation and diagnosis. If somebody has had fairly quickly started to make changes in their decision making bad financial decisions, and having major changes in personality, what test should a caregiver request of their primary doctor to start that process?
Yeah, a referral sooner than later. What I'm hearing there is what we call rapidly progressive dementia, and that is a category unto itself that requires more rapid evaluation as well. Sometimes we facilitate that by bringing up that kind of a patient into the hospital to really, in a very quick succession, get through this testing. So that would be a different category and level of concern, and kind of would merit getting specialty care sooner.
And the opposite end of that spectrum, actually, is it possible to have a type of behavioral FTD that doesn't advance or doesn't progress?
Or progresses very, very, very slowly? Absolutely. So the pedigree I just showed you, the family tree that I just showed you, that family has symptoms on the order of decades, 15 to 20 years, all FTD, all bvFTD, but just years and years and years of very slow decline, very clear decline, very slow decline. So yes, it's possible.
Great, thanks. Could a person be disqualified from participating in research studies if they know their genetic status already?
Oh, no, absolutely not. We ask, for the most part, each center handles it a little bit differently. We typically don't want to know if you know, mostly so we can treat you without bias, and do these tests, do the paper and pencil testing, the spinal fluid, just kind of not knowing. But on the other hand, if you know and you want us to know, that's absolutely fine. It's fair enough, right? We can offer you specialty advice, and it does not. The short answer is it does not preclude you from the study, no. But you don't need to know, and we don't need to know either.
And if somebody has tested negative for the C9 gene, are there other genetic tests that are recommended for the person who is affected by the disease?
I'm
sorry. So they are saying that it is a clinical diagnosis of FTD and ALS. So if the C9 gene has been found to be negative, are there other genetic tests that should be considered?
So C9 is actually a tricky genetic test, so it does kind of matter where that was done. It can be difficult to execute and interpret test. I've had patients like this as well, where we're all surprised that they were C9 negative. So then being in research studies becomes even more beneficial, because there will continue to always be a discovery phase of other genes. Is there anything else that's is the basis of that disease? So nothing commercially that could be ordered, but through research studies, it will continue to broaden our understanding.
Okay, thanks. At what point should somebody with behavioral FTD stop driving, and what is the doctor's role in helping with that determination?
Yeah, so driving in general is is fraught territory and probably could be another session unto itself. But there isn't a time to say that if you're at this stage or that stage. The American Academy of Neurology says that when people are even mildly affected of whatever dementia type, we should start the conversation about driving and driving safety. We have formal driving evaluations available through occupational therapists or rehab institutions, where they do some paper and pencil testing and some on-the-road driving. People have different practice preferences about whether it's meaningful to have a baseline evaluation and then when someone changes to have another one. Often those come out of pocket, so I tend to be of the latter variety, that if there's a concern, that's the time to get the testing done. Each state law is different about driving. There are only 2 states I'm aware of that have mandatory reporting on the part of the physicians for folks with dementia and pulling their license. Every other state, we can certainly fill out a form and have the patient's license pulled. This is always in discussion with the family. We're not doing anything behind their backs. In the state of Missouri, 90% of the time, that's all that has to happen. There is an appeals process, but 90% tells you that that doesn't happen all that often. So it varies from state to state for sure.
And I think we're at our limit, but I have 2 last questions for you in our rapid fire session, which you've been wonderful to do. So what if somebody's already considered to be in the late stages of possible behavioral FTD? Is there any action the family should be taking? And I think that question is really, what's the role of further evaluation at that point if the person has progressed and the diagnosis maybe isn't clear? And I hope that's the right interpretation of the question.
So I think further evaluation becomes diminishing returns potentially at that point, is I think we can all cogitate about what subtype, and I encourage my colleagues to not do this, because at the end of the day, you have a very challenging loved one on your hands, and really have to make sure that the loved one is in safe hands, as is the family members. So I often am asking about how if the caregivers feel that they're safe in their own home, and really kind of being very patient focused at that point in time, and that really does it much matter at that stage of the game what subtype of degeneration the loved one has. So I think the focus on what probably doesn't happen early enough is power of attorney for healthcare, finances, not waiting till guardianship and conservatorship are your only options. So some of those long-term plans and placement options as well, I think should become the focus at that point.
And our last question is, with all the activity that's happening in research, in FTD research, as well as other neurodegenerative diseases, how close do you think we might be to finding treatments or a cure for this disease?
The holy grail question. Appropriate last question. So I think we're closer than we've ever been. I think having moved from the clinical presentation to the molecular approach has been pivotal. I think it allows us to think about what's going on at the end of the day in the brain cells and how to attack those and address them much more directly. So I think the time that it's taken to go from the early 1900s with Alzheimer's disease to now is going to be much, much more truncated, and already has been. So with the tau mutations discovered in 98 to now, there's already been a tremendous amount of advances made. So I think we're closer than we've ever been. I think I teach my residents and students that in their lifetime, in their career, knowing someone's molecular profile of their dementia is going to be the driving force, and it'll be like chemotherapy in terms of you have a certain percentage of tau, a certain percentage of TP43, and you need these 2 or 3 drugs to do battle. So I think that time is not as far off in the distant future as it once was.
Thank you so much. We have overstayed our time, but the conversation's been wonderful, and I appreciate so much your willingness to kind of do this rapid fire with us. All the information that you provided was great.
Fantastic questions. Appreciate it.
We covered so many questions. So with that, I do want to thank Dr. Ghoshal for today's presentation and for the discussion that we've had. I also want to thank all of you who took time to join us today. And we will post the recorded webinar on AFTD's website. It will be under the What's New section, where you can find kind of an archive of lots of good things, including the genetics webinar that I mentioned, as well as some of the other resources that we have. We'll also send out the link as soon as it's available. So if you've registered for this webinar, you will get that link directly. And as always, please let us know if you have any comments or questions about today's presentation or suggestions for future webinars and topics that we might cover. And so with that, this ends our presentation today. And until next time, thank you and best wishes to everyone for a wonderful fall.
Take care.
Bye-bye. Thank you.